Just wait for a minute, it will start. Okay.
Yes. Good evening, everybody. Today my topic of presentation is voriconazole. Uh, Voriconazole is a novel triazole antifungal agent, and the clinical needs for novel antifungal agents have altered steadily with the rise and fall of HIV-related mycosis and the change in the spectrum of fetal disseminated mycosis. The rising frequency of fetal mycosis is also associated with increasing use of immunosuppressive medical therapies, predominantly after the transplant era and after the allogenic or autogenic bone marrow transplantations and upcoming new immunosuppressive agents. The search for new molecular targets for antifungal has thus generated considerable research using modern genomic approaches. So, three new triazoles with broad antifungal spectra were introduced over the last 2 decades: posaconazole, ravuconazole, and voriconazole. Today, I'll be discussing in detail about voriconazole. The main headings under which I'll be discussing this drug is class of the drug and chemical structure, mechanism of action, indications including FDA approved and some non-licensed indications, then pharmacokinetics, dosing and administrations including mode of administrations, route of administrations, to something which is very important, that is drug to drug interactions and adverse reactions, some special considerations like in pregnancy, pediatric or geriatric population, and last one will be clinical trials. There is not much pompous literature which is available on clinical trials of newer antifungals, though I'll be highlighting some of the important FDA approved trials. So let's start with the drug class and chemical structure. Voriconazole belongs to antifungal azoles. So azoles are broadly divided into two categories: imidazoles and triazoles. These are the largest class of antifungal agents in clinical use. 1990s witnessed an expansion of the antifungal armamentarium to include these two new azole agents. One was fluconazole, which we are pretty friendly with, and the other one is itraconazole. Second generation triazole agents were introduced in the past 2 decades, and out of which voriconazole was the first of these new agents to receive approval from US FDA. Initial US approval it received in 2002. On the right side, you can see the two broad categories of azole antifungals, imidazole and triazoles. We are much aware about clotrimazole, iconazole, miconazole, which are mainly used as topical applicants, and ketoconazoles, which we used to prescribe previously for fungal infections, both topical as well as systemic up to some extent. The triazoles, fluconazole, itraconazole, which we are aware of. The newer ones are posaconazole, ravuconazole, and voriconazole. Chemical structure. So the chemical structure of voriconazole is similar to that of fluconazole, apart from few changes. It is basically a synthetic derivative of fluconazole. Replacement of one of the triazole rings with fluorinated pyrimidine. As you can see, the shaded area here, the fluconazole, it has two triazole rings. That is the ring which contains double bond nitrogen atom. On the right side, this nitrogen ring is replaced by fluorinated pyrimidine ring, and we can see just on the right side of the OH group there is a vertical line which depicts alpha methyl group. So these two newer substitutions were there, and it has led to expanded antifungal activity. Because of this chemical structural change, voriconazole has experienced pretty expanded antifungal spectrum. Mechanism of action. The principal molecular target of azole antifungals is cytochrome P450. In genetic nomenclature, it is also known as ERG11P or CYP51P. These are different genetic nomenclature categories. Cytochrome P450 catalyzes the oxidative removal of 14 alpha methyl group from lanosterol pathway. I will show a diagram, and it is much into the biochemistry, but I will try to simplify as much as possible. So this diagram shows broadly the antifungal actions of these agents, antifungal agents. So as we had seen already in the last lecture of amphotericin B, the Pauline derivative predominantly they are acting on this fungal cell membrane. And the azole derivative compounds, the azoles, their primary target of action is ergosterol synthesis at the level of endoplasmic reticulum. So as we all know that in humans, the predominant cell wall sterol is cholesterol, while in fungus, it is ergosterol. Both are synthesized from acetyl coenzyme A through HMG-CoA reductase pathway. So we can see that on the last, here you can see lanosterol. So for lanosterol to enter into the steps of pathway for the formation of ergosterol, it has to be 14 alpha demethylated. I'll come to the next slide to explain you in detail. So from HMG enzyme reductase, further steps we can see here, and lanosterol. So from lanosterol, the 14 alpha demethylation will take place to form C14 demethyl lanosterol, and this will further contribute to the formation of ergosterol. Azoles inhibit the formation of this 14 alpha demethyl lanosterol, and thus this is the step checkpoint at which they are acting. This ERG11, ERGG1, whatever we are seeing on the right side in the brackets, they are cytochrome P450 type of oxidoreductase enzymes. These are very important. They catalyzes this step. Azoles bind to this P450 enzymes and they inhibit, and put a check here. Why this is important? Because P450 enzymes are involved in a lot of drug-to-drug interactions, and that's why it carries a clinical importance. So cytochrome P450 contains a central group, an iron protoporphyrin moiety, and this iron protoporphyrin moiety gets attached to the nitrogen atom of these antifungal azoles, and thus the affinity with which this each azole binds to P450 determines the extent of the azole's inhibitory effect on different fungal species. Mechanism of drug resistance at molecular level. Uh, so let's see this. The first is reduced azole import into the fungal cell body. There is the second mechanism is stimulated azole efflux. The more drug is effluxed out, the less will be its mechanism of action. Uh, then there is sterol import. If they import more of the ergosterol directly into the fungal cell body, then the enzyme may not be acting. And enzyme overproduction. So by saturation mechanism, if there is a scarcity of the azole molecules and there is enzyme overproduction to proceed into the pathway, that will also cause the less effectiveness of the drug. Then reduced affinity of azole to P450 enzymes, and some alternate pathway and other metabolic adjustments also contribute to drug resistance. Though fluconazole has emerged as a drug which showing significant fungal resistance to neofunges, voriconazole still enjoys a broad antifungal spectra and rarely has shown to be resistant to basic species of fungus which we clinically come across. Coming to the antifungal spectra covered by voriconazole, in vitro activity for yeast, it is predominantly fungistatic, and for filamentous organism like Aspergillus, Pseudosporium and all, it is fungicidal. It is active against all Candida species, Candida krusei glabrata, that are inherently fluconazole resistance, or because of overuse of fluconazole, if they have acquired resistance to fluconazole, still they can be sensitive to voriconazole. Voriconazole also shows good in vitro activity against other yeast of Cryptococcus genus, that is Cryptococcus neoformans, Trichosporon and Saccharomyces. It is broadly active in many species of Aspergillus, including Aspergillus terreus, apart from Aspergillus flavus, which shows resistance to amphotericin B. And it has shown reasonable activity against dimorphic fungi or endemic mycosis like Blastomyces, Coccidioides, and Histoplasma. It is less active against Sporothrix schenki, which is also dimorphic fungus. Some hyaline molds which are resistant to amphotericin B are susceptible to voriconazole in vitro. And the main action for which it has received FDA approval is Pseudosporium apiospermum and Fusarium and Pseudoalescheria boydi. The names may seem little unfamiliar and complicated, but voriconazole has received FDA approval for these drugs, and they are of major importance when fungal opportunistic infections are considered in allogenic bone marrow transplant patients. So they are of clinical importance in present scenario. Coming to clinical indications, Invasive aspergillosis. Voriconazole is approved for the treatment of invasive aspergillosis, candidemia in non-neutropenic patients, disseminated infections caused by Candida species, including CNS candidiasis, esophageal candidiasis, including those who have acquired fluconazole resistance for fluconazole refractory disease. Then pseudoalisteria and pseudosporium infections. It is FDA approved for the treatment of these infections in patients who are intolerant to or infections which are refractory to other agents, especially amphotericin B. And as I already mentioned before, these fungi are refractory to or intolerant to antifungal agents, and they have emerged in current scenario as major pathogen in immunocompromised hosts. And then the last one is fusarium infections. Coming to pharmacokinetics, the route of administration of voriconazole are oral and intravenous form. Oral we can give in the form of tablets or oral suspension, and intravenous. Then it is absorbed rapidly in less than 2 hours after a single oral dose. Oral bioavailability is more than 90% when administered either 1 hour before or either 1 hour after the meal. It is not affected by gastric pH, by fatty foods, and decrease bioavailability. Fatty foods decrease its bioavailability to 80%. So we should better avoid fatty foods when the patient is on voriconazole. Voriconazole is 58% protein bound and it has a large volume of distribution. It will be rapidly taken up into the body tissues once it is into the plasma. The concentration of CSF is approximately 50% of that of plasma concentration. But as it has a large volume of distribution and it is rapidly taken up by the tissues, the concentration in the brain tissue will be higher than those of the CSF. So less than 5% of the drug is excreted unchanged in the urine. Majority of the drug is metabolized in the liver. Metabolism. Metabolism of voriconazole occurs in the liver via CYP P450 enzyme family. These are oxidoreductase type of enzymes, CYP2C9, CYP3A4 and CYP2C19, which is the most important isoenzyme involved in the metabolism. These CYP P450 enzyme system also metabolizes other drugs, and lot of drugs are there which inhibit or induce their action, and thus resulting in drug-to-drug interactions. The metabolites formed do not have any antifungal activity. CYP2C19 is the major metabolic pathway for voriconazole and is highly dependent on genetic characteristics. Like in isoniazid, we have poor acetylators or fast acetylators. Similar to that, as many as 20% of non-Indian Asians have low CYP2C19 activity and they can achieve voriconazole levels as much as 4 times higher than those of noted in homozygous subjects which metabolize the drug fast. However, it is not advised to undergo any dosage modifications in this non-Indian Asian population until and unless they have some associated hepatic comorbidities. Careful attention should be paid to monitoring of liver enzyme levels. Dose adjustments are necessary in liver dysfunction, the details of which I'll be highlighting later. And drug-to-drug interactions are, of course, of major importance in the safe use of voriconazole. Coming to dose adjustments in liver function, the standard loading dose should be used, but the maintenance dosage should be halved in patients with mild to moderate liver disease, that is in child plug classification A and B. No studies have evaluated the safety of voriconazole in patients with severe liver disease, and ideally the drug should be avoided. Dose adjustments in renal dysfunction. No adjustment in the dosage of oral formulation of voriconazole is necessary in patients with renal insufficiency. Intravenous administration should be avoided for patients who have creatinine clearance less than 50 ml per minute. Moderate renal insufficiency, that is creatinine clearance in between 30 to 50 ml per minute, results in accumulation of intravenous vehicle of the drug voriconazole. That is, the vehicle is sulfobutylyl ether, beta-cyclodextrin, sodium, SBECD. So this drug should not be used by IV route when creat clearance falls below 50. Dosing and administration. Tablet form, voriconazole is available as 50 mg tablet and 200 mg tablet. 50 mg tablet comes as a white round shaped film coated film coated tablet, and it is debossed with V50 or VOR50. Voriconazole 200 mg tablet comes as a white oval shaped film coated tablet which is debossed with V200. So in case the tablet gets mixed together and on all white tablets, of course we can check if it is embossed with VOR, we can make sure that this could be a voriconazole drug. Coming to IV formulations, voriconazole IV for injection is supplied in a single dose vial as sterile lyophilized powder containing 200 mg of voriconazole and 3200 mg of SBECD, which is a vehicle for this IV formulation. Powder for oral suspension is also available. It comes as 45 grams of powder in a 100 ml of high density polyethylene bottles. The reconstitution instructions will be provided on the bottle and we have to follow them. So after reconstitution with the liquid provided, oral suspension of 40 mg of voriconazole per ml of suspension will be formed. And it is mainly used for pediatrics and people for whom if we have to install the tablets or the drug formulation through Ryle's tube. They have a 5 ml oral dispenser and a press bottle adapter is available along with the bottle for easy installation. Coming to reconstitution and dilution of IV formulation, this is the most important part and we should be very attentive to this, especially the nursing staff is diluting and reconstituting the fluid because of certain levels we have to achieve in this case. So powder is reconstituted with 19 ml of sterile water for injection to obtain an extractable volume of 20 ml of clear concentrate. So each vial will contain 200 mg voriconazole in a powder form. We inject 19 ml of sterile water, taking 20 cc syringe to achieve a proper volume of the sterile water. We inject that volume into this vial. So we will be getting a 20 ml of clear concentrate, that is 200 mg of voriconazole in 20 ml of liquid. That is it is 10 mg voriconazole in 1 ml. It is recommended that the standard 20 ml syringe is used and discard the vial if the vacuum does not pull the diluent into the vial. Once we take out the 19 ml of sterile water into the syringe, we should inject it into the vial and automatically the vacuum should suck the liquid, the sterile water inside to form the solution. If it doesn't suck inside, the vacuum is not created. That means there has been some leak and chances of infection would have been there or drug might have decomposed. We should better avoid and discard that vial. So shake the vial upside down slowly until all the powder is dissolved. Only clear solutions without any particulate matter should be used. If any particulate matter is visualized, it should be discarded. Coming to dilution, so this up to this step we have seen about reconstitution. Now coming to dilution, voriconazole is never given as a loading bolus dose. We can give the first aid loading doses, but loading doesn't mean bolus. We should never push voriconazole directly into the IV as a bolus. It should be infused slowly over 1 to 3 hours or at least 1 to 2 hours at the concentration of 5 mg per ml or less. Therefore, the required volume of 10 mg per ml we have to further dilute. To do this, we have certain diluents in which we can dilute this reconstituted liquid. 0.9% sodium chloride, we can use lactated Ringer's solution, and we can use 5% dextrose solution in combination with lactated Ringer's or half normal saline. Also, if we want to simultaneously correct hypokalemia, we can use 5% dextrose with 20 milliequivalents of potassium chloride added to this, and as well as half normal saline combination. It must not be diluted with sodium bicarbonate infusion 4.2% because of the alkaline medium, and that will lead to decomposition of the drug. So total volume of concentrate required, we have to calculate that based on the patient's weight. So suppose I want to give voriconazole IV injection to a patient weighing 40 kg at 4 mg per kg dose. The patient's dose requirement will be 40 kg into 4, that will be 160 mg. 160 mg, so I can use one vial of voriconazole which contains 200 mg. So I will I will add the reconstitution with sterile water and I will reconstitute the solution, and out of that I will take the 16 ml of the reconstituted liquid, because each ml of voriconazole contains 10 mg of voriconazole constituent chemical. So 16 ml will contain 160 mg of voriconazole. So after taking this 16 ml, in a syringe, after drawing this, in order to allow the required volume of concentrated, I will add it to the diluent, and whatever the remaining reconstituted liquid is there in that vial, I will discard it. I will not use it for further dosing because of the contamination risk and decomposition of the drug. So this 16 mg, the 16 ml of the liquid, I have to dilute now further. So to achieve the final concentration should not be less than 0.5 mg per ml, and it should not be greater than 5 mg per ml. So suppose if I want to dilute in 0.9% NaCl, suppose if I take 100 ml of NaCl, I'm using it as a diluent, then I will what I will do is, out of this 100 ml vial, I will first withdraw 16 ml of clear NaCl and I will discard that. And then I will fill 16 ml of this reconstituted liquid into that diluent vial. So I will be having 160 mg in 100 ml of the diluent. That means the ultimate concentration will be 1.6 mg per ml. Now this is fitting into our range of 0.5 to 5 mg, and we can safely give this. So it's better always to see the volume of the diluent which we are using to dilute. We should not over dilute it or under dilute it. This solution can be infused over 1 to 3 hours with a maximum rate of infusion being 3 mg per kg per hour. It is single dose unpreserved sterile lyophil. So once it is reconstituted, ideally the product should be used immediately. Maximum storage time at 2 to 8 degrees. We can store at for 24 hours the reconstituted liquid. Once it is diluted, we shouldn't use it, we should not store it, we should use it immediately. Coming to the dosing regimen for adults, on the left side there are infections for which it is approved, and the loading dose and the maintenance dose. For invasive aspergillosis, the loading dose is 6 mg per kg every 12 hours for the first 24 hours, that is on the day 1. The maintenance dose starts from the second day and it is 4 mg per kg every 12 hours. For candidemia in non-neutropenic patients and deep tissue candida infections also, the dose is same. Esophageal candidiasis, it has not been evaluated from clinical trials and study, but we can use the same dose as we are using for disseminated candida infections, that is 6 mg loading dose and 4 mg per kg as maintenance dose. Pseudosporium and fusariasis, again the dose is same. This is IV maintenance dose, 4 mg per kg every 12 hours. For oral maintenance dose, infection maintenance dose is 200 mg every 12 hourly for all the above mentioned infections: aspergillosis, candidemia, esophageal candidiasis, and as well as pseudosporium and fusarial species. Recommended dosing duration. Now there are different studies gives different durations. For invasive aspergillosis and serious fungal infections with fusarium and pseudosporium species, the treatment must be initiated with a specified loading dose regimen of intravenous voriconazole on day 1. So ideally loading dose is always considered as IV unless there are absolute contraindications, followed by recommended maintenance dose. Preferably for invasive infections, intravenous treatment should be continued for at least 10 days. Switching between intravenous and oral formulation is appropriate because of the high bioavailability of the oral formulation. So once patient is clinically stable, starts taking orally, we can switch to oral regimen. Median duration of treatment is IV 10 days, ranging from 2 to 90 days, and per orally it is 76 days, ranging from 2 to 232 days. So this is a very wide range, but ideally in disseminated infections, the treatment may go on for approximately 2 to 3 months. Candidemia in non-neutropenic patients and other deep tissue candida infections, patients should be treated for at least 14 days following the resolution of symptoms. That means if the symptoms resolve after 7 days of treatment, we have to continue additionally for 14 days the treatment, either IV or oral, or following the last positive candida culture, whichever is longer. So either give for 14 days after resolution of symptoms, or just go on tracing the last positive culture, whichever is longer. Esophageal candidiasis, patient should be treated for a minimum of 14 days and for at least 7 days following the resolution of symptoms. Methods for adjusting the dosing regimen. This is another important topic. If patient's response is inadequate, the oral maintenance dose of 200 mg 12 hourly can be increased to 300 mg 12 hourly. 200 mg 12 hourly is almost equivalent to 3 mg per kg of voriconazole, and 300 mg 300 mg every 12 hourly is approximately equal to 4 mg per kg of IV itraconazole. For adult patients weighing less than 40 kg, ideally we start with 100 mg BD dosing, but if patient's response is inappropriate, we can increase from 100 mg to 150 mg every 12 hourly. If patient is unable to tolerate 300 mg orally every 12 hours, step by step we can reduce 50 mg per day to minimum of 200 mg 12 hourly. Adult patients weighing less than 40 kg, if they are not tolerating the 150 mg dose, we can go back to our 100 mg 12 hourly regimen. IV regimen, if patient is unable to tolerate 4 mg per kg intravenous dose, we can reduce from 4 mg to 3 mg per kg, not below that, because then the dose will be suboptimal. Use of IV voriconazole with other parenteral products. Can we give it along with other electrolyte solutions? Well, voriconazole must not be infused concomitantly with any blood products or any short-term infusion of concentrated electrolytes like 3% NaCl, or short-term we are pushing calcium gluconate. We should not give in the same intravenous lines. We can give non-concentrated electrolytes uh, on the same this thing, but not through the same QA or same three-way. We should give them from separate intravenous lines. Electrolyte disturbances such as hypokalemia, hypomagnesemia, and hypocalcemia should be corrected prior to the initiation of and during IV voriconazole therapy. This is very important because voriconazole has cardiac rhythm defects. It can cause QT prolongations. It can precipitate arrhythmias. So correction of electrolyte disturbance is very crucial. You can either do it prior to starting voriconazole therapy or during the therapy itself simultaneously through separate IV line, but that has to be looked into. It's mandatory to check for potassium, magnesium, and calcium levels before starting IV voriconazole. Intravenous solutions containing non-concentrated electrolytes, yes, we can give, can be infused at the same time as other intravenous solutions containing non-concentrated electrolytes, but must be infused through a separate line, separate port or separate line, not through the same QA. Total parenteral nutrition can be infused at the same time as total parenteral nutrition, but again it should be infused through separate line or port. Dose modifications in hepatic impairment. Dose adjustments are not necessary in patients with baseline liver function test AST/ALT up to 5 times the upper limit of normal in asymptomatic patient. Asymptomatic transaminisemia up to 5 times the upper limit of normal does not require dose modifications. But however, continuous monitoring of liver function test is mandatory if we have to keep a check on further elevations we are noticing. It is recommended that IV voriconazole full dosing be used, but maintenance dose should be halved in patients, adult patients with mild to moderate hepatic cirrhosis, that is Child-Pugh class A and B. Voriconazole has not been studied in adult patients with severe hepatic cirrhosis, that is Child-Pugh class C, and in patients with chronic hepatitis B and chronic hepatitis C disease. It should only be used in patients with severe hepatic impairment if the drug is, if the benefit outweighs the potential risk, and we don't have any other drug which is safe in such a condition, but it should be patient-based approach. Ideally, we should avoid it. Patient with hepatic impairment must carefully be monitored for any signs of drug toxicity. Dosage adjustments in pediatric patients in hepatic impairment has not been established, and ideally we should avoid using it in pediatric patients with hepatic impairment. Dose modifications in renal impairment. Pharmacokinetic of orally administered voriconazole is not significantly affected by renal impairment. So no adjustment is necessary for oral dosing in patients from mild to severe renal impairment. As I already mentioned that creatinine clearance less than 50, avoid IV formulation because accumulation of intravenous vehicle SBCD occurs. And assessment of risk versus benefit, when we should give, we should not give. That should also be a case-based approach. Serum creatinine levels should be closely monitored in these patients, and if creatinine increases, consideration should be given to changing from IV to oral regimen. Hemodialysis. Voriconazole is hemodialysable with a clearance of 121 ml per minute. Its intravenous vehicle is also hemodialysable. 4-hour hemodialysis session, which we routinely do in our CKD patients, does not remove a sufficient amount of voriconazole to warrant dose adjustments. However, 6 hour more than 6 hour prolonged hemodialysis will bring down the concentration of voriconazole. Dosage adjustment in voriconazole in pediatric patients with renal impairment has not been established, and ideally it should be avoided. Coming to drug interaction, which is the most important topic, the potential for drug interactions with voriconazole is high because of its metabolism by CYP450 isoenzymes. And voriconazole inhibits the activity of cytochrome P450 isoenzymes, predominantly 2C19, 2C9, and 3A4. So there is a potential for voriconazole to increase plasma concentrations of those substances which are metabolized by these enzymes. We have a huge list of this, and it is important because a lot of drugs are given in patients who have HIV, since HIV and fungal infections go hand in hand, as well as they are important from neurology point of view as well as the physician point of view, because you will be highly surprised to see a lot of these drugs we do give left and right in our neurology practice. Coming to first drug, rifampin and rifabutin. We use it commonly. We use it for tuberculous infections, CNS tuberculosis. So significantly reduces the level of voriconazole. Voriconazole increases rifabutin plasma concentration, so it is contraindicated. Efavirenz, efavirenz 400 mg every 24 hourly. It reduces the concentration of voriconazole significantly, and thus it is contraindicated. Efavirenz 300 mg every 24 hourly. Well, when voriconazole is co-administered, voriconazole oral maintenance dose should be increased to 400 mg every 12 hourly from 200 mg, because efavirenz 300 mg reduces the voriconazole concentration. So we should double the dose. But when it comes to 400 mg efavirenz, ideally it is contraindicated. We should not give. Coming to protease inhibitors, high dose ritonavir as well as low dose ritonavir. Well, you see on the right side, ritonavir 400 mg is contraindicated, but low dose ritonavir also should be avoided ideally, because significant reduction in the level of voriconazole, they will decrease the efficacy. Coming to the next, one of our favorite drugs, carbamazepine, which is a CYP450 inducer, as we all know, results in significant reduction of voriconazole drugs, so thus contraindicated. Long-acting barbiturates like phenobarbital, again significant reduction in voriconazole, and it is contraindicated. Oral contraceptives containing both estrogen and progesterone combination, the levels are increased. Voriconazole levels are increased, so we have to closely monitor the adverse and toxicity related to voriconazole. Ideally, patients should avoid taking oral contraceptives when they are on voriconazole therapy, and ideally we should offer them barrier contraception when they are on voriconazole therapy. Fluconazole, can we give fluconazole along with voriconazole? Well, there is significantly increased concentration of fluconazole and toxicity may result, so avoid concomitant administration of voriconazole and fluconazole. Generally, the spectrum which voriconazole covers is more than that of fluconazole, so there will be a less chance that we will be giving two of them together. Coming to the other drug, it's as we have seen that this fungal infection, especially invasive aspergillosis and all those molds, pseudosporium and all, they are very common in transplant patients. When it comes to transplant, we have sirolimus and tacrolimus there. So their concentrations are significantly increased. So the drug is contraindicated. They increase the level of voriconazole as well. So reduce the dosage to 1/3 and monitor levels closely. Sirolimus is contraindicated. For tacrolimus, we have to reduce the dose to 1/3 and monitor levels. Then cisapride, pimozid, quinidine, terfenadine, and astemizole. These are all drugs causing significant QT prolongation, so they are absolutely contraindicated. Coming to ergot alkaloids, which we use for migraine headache patients, they have not studied in vitro and in vivo, and plasma drug exposure is likely to be increased. And voriconazole increases significantly the ergot levels in the blood, so it is contraindicated. It can precipitate ergotism. Coming to phenytoin, we do require frequent monitoring of phenytoin plasma concentrations and frequent monitoring of adverse effects related to phenytoin concentration, because the phenytoin levels are increased and even the voriconazole levels will be increased. So closely monitoring the toxicity. Ideally, it should be avoided. Warfarin, prothrombin time is increased because and monitor the PT and other suitable anticoagulation tests. Coming to fentanyl, when patients are serious, critical in ICU, most of them, they are on fenta infusion and on other long-acting opiates. Voriconazole increases the level of opiates, so reduction in the dose of fentanyl and long-acting opiates, which are metabolized by CYP3A4, should be considered when co-administered. NSAIDs including ibuprofen, diclofenac again. Frequent monitoring, voriconazole can increase the level of toxicity. So we should closely look for the toxicity related to NSAIDs and dose reduction should be required. Sirolimus we have already seen is contraindicated, but even everolimus, concomitant administration of voriconazole and everolimus is not recommended. Coming to another common drugs, sulfonylureas or oral hypoglycemic agents, frequent monitoring of blood glucose, chances of getting hypoglycemia are very high. So adjustment of oral hypoglycemic drug, not reducing the dose of oral hypoglycemics is warranted. Better we can switch the patient to actrapid or insulatard, that is regular human insulins, and we can better control the sugars rather than throwing the patient into bad hypoglycemic episode. So phenytoin decreases voriconazole level and the oral dose of voriconazole should be doubled and phenytoin levels should be closely monitored. Cyclosporin, reduce the dosage by half and monitor levels. Care should be taken with concomitant administration of statins because again toxicity can be precipitated. Benzodiazepines, calcium channel blockers, sulfonylureas, proton pump inhibitors which we give commonly and vinca alkaloids. If we are giving omeprazole, reduce dosage by half. Dosage of this drug should be decreased or their markers of their activity should be carefully monitored. Like if patient is on sulfonylureas, monitor blood sugars tightly, or if he is on calcium channel blockers, monitor blood pressure very closely. And if any signs of toxicity are seen, reduce the dose of these drugs. Voriconazole is contraindicated in patients with known hypersensitivity to voriconazole and its recipients. There is no information regarding cross-sensitivity between voriconazole and other azole antifungal agents. So better caution should be used when prescribing voriconazole to patients with hypersensitivity to other azoles. Drugs that do not require dose adjustment include cimetidine, digoxin, indinavir, macrolide antibiotics, mycophenolate. Yes, we cannot give cyclosporin. Tacrolimus dose has to be reduced, so mycophenolate is an option. Prednisolone can be given safely without dose adjustments, and instead of omeprazole, we can consider giving ranitidine. Coming to adverse reactions, hepatotoxicity, we already discussed liver enzyme elevation. Hepatitis, cholestasis, and fulminant hepatic failure had been reported in patients, including fulminant hepatic failure and deaths due to that. Serum transaminase and bilirubin levels should be measured at initiation of therapy, then weekly for 1 month, and then monthly monitoring till the end of therapy. Arrhythmias and QT prolongation. Rare cases of arrhythmias, torsades de pointes, cardiac arrest, and sudden cardiac deaths have been observed. So these patients usually involve seriously ill patients with multiple confounding risk factors like diabetes, hypertension, and in addition to that, there could be cardiotoxic chemotherapy which would have been given, cardiomyopathy, hypokalemia, and concomitant medications. Voriconazole should be administered with very much caution to patients with potentially proarrhythmic potential, like congenital or acquired QT prolongation, cardiomyopathy in particular when heart failure is present, sinus bradycardia, existing symptomatic arrhythmias, and concomitant drug like pimozid, astemizole, or terfenadine. These drugs which can prolong QT interval, this drug should be avoided. It's better to take a baseline ECG and to take a history from the patient whether he had suffered any of such events. Infusion-related reactions. Anaphylactoid type of reactions, though they are uncommon, they have been observed. Flushing, fever, sweating, tachycardia, chest tightness, dyspnea, faintness, nausea, pruritus, and rash. Symptoms appear immediately upon initiation of infusion. So consider stopping the infusion should these reactions occur. Coming to an interesting side effect, visual disturbances. Literature gives a wide range. They have been reported from 18% to up to as good as 30% of patients. So altered color discrimination, blurred vision, the appearance of bright spots, wavy lines, photophobia, as well as photopsia, that is flashes of lights patients experienced. Symptoms tend to occur during the first week of therapy and they decrease or disappear sometimes in spite of continued therapy in most patients. However, in some patients, they may persist till the end of therapy or even after the end of therapy. Rare reports of optic neuritis and papilloedema had been noted in post-marketing surveillance of the drugs. Visual hallucinations have occurred in 5% of the patients in one clinical trial, patients seeing different waveforms, different images and bright spots in front of their eyes. Patients whose therapy is initiated as outpatient, we are giving oral medication of voriconazole. They should be asked to avoid driving. Mechanism of action of visual disturbance is not exactly known. However, the site of action is most likely to be within the retina. Investigating the effect of 28-day treatment with voriconazole on retinal function, it was found that electroretinogram waveform amplitude was reduced, there was decrease in the visual field, and there was alteration of the color perception. 14 days after the end of dosing, when the treatment was stopped and the same electroretinogram and visual evaluation was performed, after 14 days of the end of treatment, it was seen that ERG, visual fields and color perception returned to normal. If treatment continues beyond 28 days, visual function including visual acuity, visual field and color perception should be monitored. If patient is already having any of such a defects or gives history of any previous diminished vision, it's better to have a baseline visual assessment prior to starting voriconazole therapy. So this adds to our checklist. Coming to another important side effects, that is skin rashes, which are seen in 5.3% of cases, and photosensitivity. Skin rashes itself generally are mild and constitute no major problem. However, serious exfoliative cutaneous reactions like Stevens-Johnson syndrome, toxic epidermal necrolysis, erythema multiforme have been reported rarely. Patients should be warned to avoid direct sunlight, wear protective clothing, sunscreens with good sun protection factor, especially among children because they are more prone for developing photosensitivity. Then other phototoxic reactions like pseudoporphyria, cheilitis, and cutaneous lupus erythematosus have also been reported. If phototoxic reactions occur, the patient should be referred to a dermatologist promptly and voriconazole discontinuation should be considered. If voriconazole to be continued despite the occurrence of phototoxicity related lesions, it is the drug of choice, we don't have much other options, well, okay, go ahead, but dermatological evaluation should be performed on systematic and regular basis. Squamous cell carcinoma of the skin and melanoma of the skin have been reported during long-term voriconazole therapy. So if patient develops any skin lesion consistent with pre-malignant lesion, squamous cell carcinoma or melanoma, voriconazole should be discontinued. Frequent phototoxicity reactions is higher among pediatric population. So we should keep a keen eye on examining children those who are experiencing photoaging injuries like lentigens and ephelates. Sun avoidance and regular dermatological follow are recommended even after the treatment discontinuation to look for any changes into the malignant lesion. Coming to skeletal adverse reactions, this was another unfamiliar side effect which we had never heard of. That is fluorosis and periostitis, which had been reported during long-term voriconazole therapy. If a patient develops any skeletal pains, bone pains, or any radiological findings compatible with fluorosis and periostitis, voriconazole should be discontinued. Lactose and galactose intolerance, these are comparatively rare side effects, but the voriconazole tablet contains lactose and the oral suspension contains sucrose, that is a table sugar. So ideally this should be avoided in patients with hereditary problems of galactose intolerance, lactase deficiency or glucose galactose malabsorptions. Coming to pancreatitis, pancreatitis has been observed in patients undergoing treatment with voriconazole. Patients with risk factors for acute pancreatitis, like if they have received chemotherapy, like L. asparaginase, hematopoietic bone marrow transplantation, should be monitored for development of pancreatitis. Look for abdominal pain, serum monitoring of serum lipase amylase should be there. Renal toxicity. Acute renal failure has been observed in patients undergoing treatment with voriconazole. Patients being treated with voriconazole are likely to be treated concomitantly with nephrotoxic medications like tacrolimus, cyclosporine and all these things, because since the fungal infections are common in such a transplant recipients. So we have to always keep a check on what drugs are there on the list and we have to carefully look into them to avoid renal toxicity. may have concurrent conditions also. Many of them would have been diabetic, or many of them would have been CKD patients with baseline poor renal function. So patients should be monitored for the development of abnormal renal function. Creatinine, serum urea should be monitored. Less common side effects are general fever, body pains, headache, nausea, vomiting, diarrhea, abdominal pain. Coming to special populations, pregnancy. Voriconazole causes fetal damage. It's teratogenic when administered to pregnant women. No data are available from human studies, but animal studies like the rabbit and rat pups have shown serious fetal malformations, hydroureter, hydrouresis, this thing, and very serious increased mortality and increased rate of abortion. So it is contraindicated in pregnancy. Coming to lactation, no data is available regarding the presence of voriconazole or secretion of voriconazole in human milk, its effects of voriconazole on breastfed infant and effects on milk production. But when ideally it should be avoided in lactating mother, and development and health benefits of breastfeeding should be considered along with mother's clinical need for voriconazole. Female and male reproductive potential. Advise female on effective contraception to avoid pregnancy when she's on treatment with voriconazole. Again, we have already seen the amount of the cross reaction which takes place along with oral contraceptives. So ideally, it will reduce the, it is unlikely to reduce the contraceptive effect. It is not fully contraindicated, but it should be administered with caution. Pediatric use. Safety and effectiveness of in pediatric patients below the age of 2 years has not been established. Voriconazole is not recommended for pediatric age group below 2 years of age. High frequency of liver enzyme elevation was observed in pediatric patients, and frequent phototoxicity reactions, as we already discussed. Squamous cell carcinoma has been reported in pediatric group who have experienced photosensitivity reaction. So stringent measures of photoprotections were warranted. Geriatric use. Pharmacokinetic data obtained from therapeutic trials showed that voriconazole plasma concentrations in elderly were 80 to 90% higher than those of younger patients. Overall safety profile of the elderly patients is similar to that of young, and no dosage adjustments have been recommended in geriatric population. Overdose, there is no known antidote for voriconazole. Prolonged hemodialysis, that is for 6 hours or longer, may assist in the removal of voriconazole and SBCD from the body. Coming to the last part, that is the clinical trials. There is a pioneering trial of voriconazole comparison versus amphotericin B for primary therapy of invasive aspergillosis. This was a large randomized trial comparing voriconazole with standard amphotericin B for primary treatment of invasive aspergillosis. So out of 277 patients, 144 patients were randomized to receive voriconazole and 133 patients were randomized to receive ampho B. More than 80% of the patients in both treatment groups had invasive pulmonary aspergillosis and had hematological malignancies, and most of them were stem cell transplant recipients. Complete or partial response at week 12 was compared, that is approximately after 3 months of treatment. 53% of patients in voriconazole and 32% of patients in ampho group showed complete or partial response. Survival rate was 71, which is very good in voriconazole group, and 58% in ampho B group. These results showed voriconazole to be more effective than ampho B for primary treatment of patients with invasive aspergillosis, and for that it received FDA approval. Coming to Pseudosporium and Pseudoalascheria species, voriconazole is FDA approved for treatment of these fungal molds in patients who are intolerant of or with infections refractory to other agents. These fungi are generally amphotericin B resistant, so yes, voriconazole can be considered as the first line agent in them. Clinical experience with voriconazole treatment has shown excellent activity against Pseudosporium apiospermum, but only modest activity against Pseudosporium prolificans. So when we can always check